family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Good evening. Welcome to Dr. Gor Show. Today we're going to talk about anesthesia. You know, whenever we need surgery, the person whose hand, all our breathing, all our heart is under control is anesthesia. That's the most important person anytime we need surgery or pain management. And to talk about this important topic and make all this clarification about why we stop the medication, why pre-op we have to not eat or drink, why can't we have this, what happens when those machines are attached to us, what happens afterwards to make our transition easy, spinal blocks if you have hand surgery, nerve blocks, pain management after the surgery, and pain management during labor and delivery. All those topics will be covered today's talk. And to talk about this important topic, we have Dr. Dilip Shubedar.
Thank you.
And Dr. Janki Deegan with us. And Dr. Shubedar did his training in India, and then he came here and did his anesthesia training from New York Medical College, and then he did his specialization in pain management. And Dr. Deegan did her training right here in Brooklyn, downstate, and then she went to Philadelphia, did her training in anesthesia, and she specializes in children anesthesia, pediatric anesthesia from Children's Hospital, which is one of the world standard in medicine for children. And Dr. Shubedar has had a lot of position among Physician Association, and he's the director of Ramapo Anesthesia. So welcome to Dr. Gor Show. So I'm going to start with you, Dr. Deegan. You know, a lot of times I think we as a surgeon have face-to-face with the patients, and we talk about surgery, we talk about everything in detail, but the main person who has control of that patient is you guys. And sometimes the first time they meet you is just before the surgery. So, of course, from surgeon's point of view, we make sure that patient understands how good you guys are and how we trust them in your hands. But it's kind of a lot of trust that patient has to have in you, and it requires a great skill from your part to make them so comfortable that they give their life to you, and you're in control of the breathing, the circulation, so like all the vital functions are under your care. Now, before we even reach OR, we give patients pre-op, instructions. So if you want to go through them, why we talk about medications, their diets, why is it important that they are in the best of state before they come to you that day?
Right. So we're meeting a patient that day, that moment, maybe 20, 30 minutes before their surgery.
Right.
We want to glean every piece of information from them regarding their medical history, what medications they take, what previous anesthetics they've had, what experiences they've had. Had they had nausea, vomiting post-operatively? Had they had a mother that had a bad experience with anesthesia? Are they a smoker, drinker? What medications they take,
Sure.
Even herbal medications that patients may not
think
think
that
about,
it's a medication.
right? Those really affect our anesthetic. Also, over-the-counter medication. Oh, I take Advil every day. Some people don't think about that, but it really affects the surgical procedure as well as the anesthetic.
Correct.
So we need to know all of that information, and we have only just a few moments, as you said, to gain their trust and to get that information.
And also the dental implants, and
Sure.
if they have false teeth, correct?
And-
That's one of the very important
Right,
things.
exactly. And in that few minutes, we want to also get, as well as a history, but a physical exam. We want to listen to their heart, their lungs. We want to hear if they have a murmur, if they have any congestion in their lungs, difficulty breathing, asthma. And again, as you mentioned, an airway exam, because that is our number one concern, is
Correct.
breathing and what does their airway look like. So we ask them to open their mouth. Do you have any dental implants, any loose teeth, chipped teeth? Because actually one of the biggest risks of anesthesia is damage to dentition.
Correct.
So we always want to make sure that we're aware of that, as well as they know what risks and benefits there are to
And even like
anesthetic.
small things, like you ask them to open the jaw wide
Right.
to make sure that the temporomandibular joint is okay for you
Right.
guys to put the tube in.
Right.
So those small things, at that point, like, why are you asking
Right.
all this question to open the mouth and stuff? But they are so important because
Right.
to access their airway so they can breathe is such an important aspect from your point of view.
Right.
So apart from the exam, you have made sure also about NPO status, correct?
Correct.
We usually tell them, like, if you're doing abdominal surgery, at least 10 to 12 hours, sometimes maybe shorter if it's an emergency. But why is it so important that they haven't eaten or anything?
So it's extremely important that patients don't eat anything. The recommendation, as you mentioned, is typically we say nothing to eat or drink after midnight,
Correct.
the night before your procedure. The reason is we don't want any contents of the stomach to end up in the lungs. So
Right.
a regurgitation, that would be a high risk for
Aspiration during the
Aspiration,
anesthesia.
correct.
Because all those medication make that sphincter really relax.
Right.
So they are at very high risk at that point.
And any contents, even patients that chew gum preoperatively, increases their
Secretions.
increases the production of saliva, and that contents will be in their stomach and put them at higher risk for aspiration.
That's a very important point because, yes, you might be NPO, but
Right.
you're chewing gum.
And you're stimulating your stomach.
Stomach with
Correct.
the secretion. So
Correct.
that's something very important. Also, sometimes if it's an emergency case, you might shorter the amount of time
Correct.
needed for them to be NPO. But kind of food also really affects, right? So if they had milk products,
Yeah.
sometimes it takes a longer time for it to digest.
Correct. Especially in pediatrics, it's oftentimes we say, for children,
Right.
we say if they're formula fed, we say 4 hours
Mm-hmm.
or 6 hours formula fed. Breast milk is 4 hours because breast milk is more rapidly digested.
It's less fat, I suppose.
Correct. And then any solid foods, we'd say at least 6 to 8 hours.
Correct.
Light meals, 6 hours. Heavy meals, 8 hours. But typically, if you're having an elective planned procedure, we like you to have nothing to eat or drink after midnight and try to avoid fatty foods the night before.
Right. So, and that's why we feel that certain procedures done electively are better because we have time
To
stop
plan.
those medication, time to do that rather than become an emergent where we don't have the ideal situations of taking care of. So if there's a loose tooth, we don't have time to take
Right.
care of it. Or if they had taken painkillers that make them at higher risk for bleeding as well as post-op or especially blocks sometimes if it affects their platelet function. So coming to you, Dr. Shubhida, tell us about what are blocks, what are they used for, and how do you give those?
So there are a lot of operations which do not require general anesthesia. By general anesthesia means that patients do not have to be unconscious.
A complete sleep.
Complete sleep. For example, any surgery that you do on extremities,
Sure.
maybe lower extremities or upper extremities or head and neck or hernias, there are several operations which can be safely done without putting patients to complete sleep.
Right.
That's where these techniques of nerve blocks or regional blocks come into play.
So it's similar to what a dentist will give you for a dental extraction. They are numbing that part of the nerve so you're not feeling the sensation.
Yes, say almost same concept.
All right.
Yes.
So say for upper extremity, somebody needs like I had broken my ligaments and it needed to be fixed and they gave me a nerve block under my armpit. Now how does that work?
So science tells us that all the sensations from the extremities are carried by nerves to the brain where all the processing happens.
It passes the electric current kind
Correct.
of a thing.
So we have certain techniques in which we can isolate those nerves and make a pool of pain medications around the nerves.
Right.
These are typically local anesthetics. And what they do is they temporarily suspend all conduction of nerve impulses coming from your, for example, your fingers or your hand to go to the brain.
Right.
So in other words, by giving an injection, one extremity of yours is not communicating with the brain.
Correct.
And at that time, the surgeon can do whatever operation he has to do.
And most often time you would give some sort of sedation, right? So that way the person is a little bit in a light sleep.
Always. So even though the arm is not feeling any pain, but just the sheer presence of the operating room
Correct.
may be very anxiety provoking to the patient.
Correct.
So to that extent, there are now very nice medications which can give you temporary sedation for that matter.
Right.
So you have best of both worlds. You're not aware of the surroundings, you're not unconscious, you're breathing on your own. Some people are listening to the music, and yet you're unaware completely of what's going on as an operation.
Right. Now, does this require a special technique, any special preparations from you or the patient or the surgeon?
Not from the patient, but from one is that this operation that is intended should be such that a regional block is good for.
Correct.
For example, if there's a very big surgery to be done on the upper extremity, you really can't do regional blocks because there is a limitation of time.
Of the time, how long can you numb that area?
Exactly, and then in other words, the person himself is not going to be so comfortable lying in that same position for such a long time. So barring those examples, the regional anesthesia is going to be a agreement which is made between the anesthesiologist, the surgeon and the patient.
Correct.
Everybody has to be on the same page. It's quite possible, and we see patients all the time who want to go to sleep. You tell them
They have a different expectation.
they have a different expectation. So we do that for them. There are surgeons who say they know, I would prefer general anesthesia. So we would do that. But in other circumstances, if everybody is on the same page, nerve blocks and regional anesthesia is a very elegant way.
And much safer, I would say.
Much safer.
Right, because you're not attached to those machines and you're not completely deep asleep. So apart from that, how do you isolate it? Do you use ultrasounds to make sure you're at the right position, or is just the anatomical areas that you help
Generally
you decide?
now in our group we use ultrasound for most of the blocks.
Correct.
Be the leg, be the arm, be the groin, ultrasound is becoming now a standard of practice.
Correct. So what I can gather from what you've said so far, I think the regional blocks or the nerve conduction blocks helps mainly for the orthopedic procedures, the joints and the hands and the neck and some hernias, as you mentioned.
That's correct.
But there might be certain position where the procedure where it's not useful, like abdominal procedure where you really need to relax somebody. So not everybody is a candidate for blocks. So I just want to clarify that. I don't want people to go home and say, oh, my appendix can be done under regional anesthesia. So only a few procedures might be done with the blocks.
You're
correct?
absolutely right.
So that, I think, is a good point that we've
Yes.
covered. Now, epidural kind of falls in that block area too.
Yes.
So in obstetrics, for the pain management, we have epidural anesthesia. So just for our patients, to take the anxiety off, tell us briefly, how does epidural work?
Now, epidural is again the same concept that our spinal cord is the main highway,
Right.
so to speak, which conducts impulses from rest of the body to the brain.
Right.
From the spinal cord, nerves come out throughout the whole segment. They start from the chest, abdomen, and it goes down. So if we are able to provide an anesthetic or a local anesthetic, which is a drug which conducts blocks pain,
Correct.
and surround the epidural nerves in the epidural space, that part of the body is going to be numb for some duration.
Right.
So if there are surgeries to be done in the lower extremities, I would say hip and below, where you don't need to relax the patient as much as you need in abdominal or thoracic surgery.
Correct.
Then an epidural or a spinal way.
A saddle block.
Saddle block is another way to do rectal procedures, for example.
Correct.
There the numbness is even more localized. So the idea is to just numb that area which is required for that operation. But by using a slightly modified technique, the laboring mothers, they're not confined to their beds.
Okay.
They can sit on a chair.
Right.
They can take a few steps. Some people believe that that will enhance the progress of labor.
Correct. So you still have the catheter in.
We still have the catheter in, but and they are being monitored very carefully.
Correct.
You are monitoring their fetal heart sounds, and yet the patients are a little bit more mobile.
Correct.
Rather than being confined to
And
bed.
I hear this question time and time again. Is my epidural going to affect my labor? Is my epidural? And we have we spend such a good time explaining to patients that it used to be different epidural before, where there was a sensory as well as motor block. Now it has evolved into mainly sensory block, so they can still push the baby. They don't need forceps, as they've seen, everybody who got epidural at one point needed forceps because they had no sensation of. So do you agree with that kind of counseling
Definitely.
that we do, that
And
it has become such a safer and so evolved process as
Yeah,
far as...
and I think Dr. Deegan does this all the time.
Yeah. And typically what we do, and we explain to them that it's not systemic medication, so it's never going to get to their circulation, affect the baby either.
Right.
That's one big concern. The risks are very minimal. Patients are generally comfortable, but we want them to feel the pressure of the contraction without feeling the pain. So this way they can labor and they can push the baby out
Exactly.
vaginally. Some patients, they have the epidural in place and they need to have a C-section. But then again, it's a perfect anesthetic because it allows us to give them stronger medications that will allow them to have a surgical procedure.
So they don't need another spinal?
Correct. They don't need any other procedure done. It's one single catheter. It remains in throughout the duration of their labor. And it allows us, even after their labor, we usually leave it in. So if there's an issue with bleeding postoperatively or any other retained products, anything, we can have the access to still provide them safe and comfortable anesthetic.
So that's a very comprehensive evaluations, why we do pre-op evaluation. What's a regional block? So we're going to take a short break and we're going to come back and talk more about general anesthesia, pediatric anesthesia, and post-op pain management. We'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back to Dr. Gor Show. So today we're talking about anesthesia. Most people don't even meet anesthesiologists before surgery, and they have a lot of questions about anesthesia. So I think it's a very important topic with anybody who might need surgery or they've had surgery in the past to kind of see how this thing works. So to talk about this important topic, we have Dr. Shubedar and Dr. Deegan with us. You do have, I've seen the old machines, and now I see the new machines. I think the anesthesia has become so sophisticated. I see they put some strips on the head so they kind of know the cerebral activity. They keep the temperature in the right place. So you guys have turned things from just nitrous to just gases to such a beautiful science behind how this anesthesia is working.
And not only is it a science, but there's a real art to it.
Correct.
It's years of experience and, like I said, synthesizing data, heart rate, blood pressure. This monitor that you speak of, it's called a BIS monitor. We use that for patients that are at higher risk for recall. And we will give patients that are at higher risk for recall memory blockers, medication that try to prevent that recall from occurring. So we do have a very specialized technique to try to prevent those experiences.
And I think that's so great. I think it's better to have surgery in today's age than going 20, 30 years back. Now you specialize in pediatric anesthesia. How is it different? Like, what do you make? Because firstly, it's such a hard, being a mother, to see if your kid needs a surgery. So that's a big step to do. And the anxiety that the parents have, sometimes the children do feel it, and they are anxious by themselves. How do you make it such an easy transition from your point of view, from outside world, to take them into the operating room?
As a pediatric anesthesiologist, my biggest thing is communication. I like to make sure that the family is aware of what to anticipate from start to finish. So when I meet a family, I'll tell them what to expect from the minute we start talking to the minute the patient is about to leave and go home. Typically what we do is I try to allay anxiety just by going over what to anticipate. And also we give the patient whatever the age may be, 1 to up to 10 or 12 medications to try to prevent any separation anxiety, any fear.
So you're kind of calming them down.
Help them forget most of what's going to happen before we even get into the operating room.
Sure.
And at Ramapo, we allow the families to come in. We typically allow one parent to come back so that the mother or the father, whoever it may be, will be there with the baby or the child as the child is going off to sleep.
Right.
I also typically don't start intravenous on a baby. We usually use a mask induction, which is a very gentle technique. Generally, I tell a story. I'll tell them that they're going on a plane ride or a spaceship or a princess mask and try to get them involved in the technique of going off to sleep. Oftentimes, I tell parents, children do have abnormal movements when they're going off to sleep, involuntary movements, arms and legs, eyes rolling back, but that's all normal. It's a part of the anesthetic. It's what we anticipate. And once the child is completely asleep, we safely escort the family out and we start an IV. We typically have two anesthesiologists or 2 members of the anesthesia team available when there is a child.
Right.
One to manage the airway, one to start the IV. Once the IV is in, we give pain medication, anti-nausea medication. One of us is with them the entire time, making sure they're safe and comfortable.
And post-operatively, while they're waking up, do you do something different than the adults?
Well, typically I'll wake them up and keep them pretty sleepy until we get to recovery room. I'll get the parent right away so that the child wakes up to see their mom or their father's
There's
face.
no stranger that the
So
first person.
they wake up and they feel as though they've just taken a nap.
Sure.
They may experience pain, but we do give pain medication, anti-nausea medication, as I said. Those are the biggest issues.
Of
Because
course.
most of the children come for typically ENT procedures. Ear tubes, tonsils, adenoids, those are the typical things. We do have children coming for pediatric urology procedures, such as circumcisions, hypospadias repairs. And for those children, not only do we do general anesthesia, but we do regional anesthesia, which would be a caudal, similar to an epidural.
Right.
We give a small dose of local anesthetic. It allows them to just have a sensory nerve block from the waist down, so they don't have
to
too
enable
much.
to do the urological
Right,
procedures.
and they don't have that much post-operative pain. They're pretty comfortable.
Right. So coming back to you, Dr. Shubheda, tell us now this patient is up and about. How do you manage the post-op pain? Because that's your kind of forte.
Yeah, so at Ramapo Anesthesia, we pride ourselves saying that we are truly patients' advocates, which means our job doesn't really stop in the operating room.
Right.
Not only do we have to provide a safe anesthetic in the operating room, but we want to make their stay in the hospital, if they're staying with us, comfortable and pain-free.
Okay.
As you know that nowadays, majority of the patients are going home the same day.
Right.
Very few patients stay in the hospital after major surgeries. So I'm talking about people who are staying over in the hospital. Let's say an example is knee replacement surgery, which is typically done inside the hospital setting. These people will stay in the hospital for about 4 days, and then they will go to a rehab center. So even if they have had an excellent anesthetic course inside the operating room, knee procedures are typically very painful.
Right.
So in order to be able to make them comfortable, we provide different techniques for pain management. This will include a patient-controlled analgesia, which is a machine which enables the patient to get the pain medication where and when they want.
Right. So they are in charge.
They are in charge. Typically what was happening in older times is that by the time the patient asks for pain medication and it is given to them by a nurse,
there was a long
time.
waiting period.
So we have taken that completely away and given the pain control in the hands of the patient.
But there is a safety also. They can't overdose themselves.
It's completely safe. It's all electronically calculated by an anesthesiologist and programmed into the computer. I've never seen any problem with the machines as such yet, and it is a safe way.
Right.
In addition, for a knee operation, we are doing what is called a femoral nerve block.
Right.
Again, as we discussed previously before the break, it is a nerve which supplies the knee joint.
Correct.
So by putting a catheter and continuously giving a local anesthetic, which is a pain blocker, for the first 2 days, these people have very little pain. And the advantage of that is that nowadays we want the patients to mobilize, to move the knee the very next day,
Right.
which was not possible a few years ago.
Right.
So by combining techniques and being on top of them, we are able to provide a very safe
A smooth transition.
transition.
Correct.
Similarly, for major abdominal surgeries or major thoracic surgeries, we are doing epidural catheters, which are placed by the anesthesiologist room before the operation.
Right.
So even when they're waking up in the recovery room, we've already dosed those catheters with pain medication. So when they're waking up, they are waking up with less pain.
Sure.
And it is very important that pain be controlled as aggressively as in the operating room, because it has got a beneficial effect. For example, if a patient moves, if a patient walks, if a patient takes a nice deep breaths during the recovery period, we do avoid complications of venous thrombosis,
Absolutely.
pneumonias, coughs and everything else.
And paralytic ileus, if they're walking around, their bowels are moving faster. So the recovery, it definitely, as far as they're mobile, is definitely going to help how they do post-operative. And we can prevent a lot of complications, which used to be very common after major surgery of blood clots and lung issues.
Exactly.
Atelectasis. So I think you brought up a very good point that not only the anesthesiologist is important during surgery, but how the post-op, that smooth transition, is a great thing.
Yeah. The other thing which I'm seeing is that in previous years, the gold standard of pain control after the operation used to be morphine.
Correct.
Morphine belongs to a class of drugs called opioids. All the opioids medication have got a notorious side effect of nausea and
Nausea and
vomiting.
constipation
And nobody likes that. I mean, there was a study performed in which they interviewed patients recovering from surgery, in which they said, what would you prefer, more pain or more nausea? Everybody said that they do not want nausea and vomiting.
Absolutely.
So these mixtures of regional blocks, epidurals, and patient-controlled analgesia minimizes all the secondary side effects of these opioid medications.
So that's a very good point, and I think today we talked so much because I think people talk about a lot of diseases and surgeries, and we talk, but I think anesthesia is almost kind of not brought into limelight, and I'm so glad we could bring this topic today to all our viewers. So to take home messages, please make sure that whatever instructions are given before the surgery you follow. Make sure you give all the history to the doctor who's asking you at the time. That way they can give you the medication without interfering with the medications you've taken and make your recovery a safe procedure. And there are different alternatives to general anesthesia, block, and post-op managements. If there's any more questions, please email it to me. You can view this show again on www.youtube.com and click on Dr. Gor Show, and you'll be able to see this show again. If your friends missed it, they will have opportunity to see it again. The website for these doctors is there. They practice in New York, New Jersey, Pennsylvania, so they cover a wide range, and they really, really, truly specialize in patient advocate. Good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.